Right.
Welcome.
Thank you very much. How are you doing? How's everything?
Everything is
It's
fine. Yeah.
good, fine. It's Carnival in Portugal.
Oh,
Carnival.
is it? All right. Pretty sure it's fun.
It's
Yeah.
fun. Yeah.
I'm in India now for a meeting.
Okay. Is it the Neurosurgical Society of India, right?
Yes, yes, this is
Okay.
the society meeting. And I will pass tomorrow to Goa meeting for complications.
Oh, okay.
Two meeting at one time.
Two in one.
Busy
Yes,
man.
it is. Welcome, everybody. I
Thank
think
you.
Yahya did not appear yet, but we have 2 more minutes.
Okay, we should start in time, Mehmet.
We should start in 2 minutes.
Okay, wonderful.
We have some more time.
Mehmet, when you think it's we should start, you just tell me.
Um, I think now we can start at 6 p.m. This is a continuation of our update of spine surgery webinars, and this time we will talk on complications. And I think one of the most characteristic features of a successful surgeon must be the surgeon who is trying to avoid complications. Oscar, my dear friend, will be the moderator. And yes, Oscar, it is
Yeah, thank you,
your
Mehmet.
turn.
First of all, I have to thank all the participants. So, welcome to the 16th update webinar on spine surgery, organized by International Academy of Spine, Middle East Spine Society, and WFNS Education and Training Committee. As Mehmet said, we are dealing today with the complication avoidance in anterior cervical spine surgery. Anterior cervical spine surgery is probably one of the most done surgeries by common spine surgeons. And I think it's interesting to know what are the complications to counsel properly the patients, and especially for surgeons to avoid those complications in order to have a better outcome. So we have here several topics, and obviously the first one, it's approach-related complications presented by Murat Sakireksi. I don't know if I said your name correctly.
Correct, sir.
So you can start presenting yourself, and just you please stay in time with the allocated time for presentation. We are eager to listen to you. Please
Thank
share your presentation.
Thank you. Good morning, good afternoon, good evening, all my colleagues. I'm from Istanbul, Turkey. I'm neurosurgeon. I'm professor of neurosurgeon. I'm also have become editor-in-chief of World Neurosurgery recently. And I'm going to talk about approach-related complications of anterior cervical surgery. Can I start?
Yes, please.
You can share the screen.
Okay. I'm trying to do it, but
So in the bottom middle,
yes.
share the screen.
There's a problem. I think I'm pushing on the share screen.
Okay.
Okay, this one. Sorry for delay. Can I do my speech in the second line because there's a setting problem related?
No problem. You can
I
probably
will deal it with now.
you probably can go out and reconnect again.
Okay.
Okay. So no problem. So next lecture is up to Ruli Anif Dahlan, and he will talk us about vertebral artery injury and esophageal injury in anterior cervical spine surgery. And I'm eager to hear his presentation, as I'm one of the fans of vertebral artery management in cervical surgery. Please unmute yourself and share your screen.
Okay, thank you, Oscar. We'll start the presentation. Just a second. Wait a minute. Oh, I have to share first. Huh?
Okay, so just
okay.
put on
Can you see that?
Perfect.
Okay.
Please proceed.
Yeah. Okay. Thank you. A good day, everybody. Professor Girelli. Yesterday we met. Yeah, it's about vertebral artery and esophageal injury. This is a very important complication. Then both of these complications happened to me actually. So maybe I will about taking a history about myself. And this is more complication that we have to deal with it, and it's have a fatal effect to the patient. Yeah, technical complication in spine. Sorry. Yeah, technical complication in spine surgery always arise from the over-aggressive handling of soft tissue or from hardware failure. We have to note the over-aggressive means it's rude at the handling of the instrument to the patient, and the other complication is poor patient selection, incorrect diagnosis, wrong chosen approaches, inadequate history taking, so it will lead to inadequate decision, inadequate operation skill, and also injury to normal anatomic structure. This is what we will talk about. And another upper cervical spine complication is CSF fistule, severe tongue swelling for transoral approaches, hemorrhage, meningitis, and retropharyngeal abscess. And we know that a ventral approach has many complications that we can list. Actually, this is from the book that written by Professor Gileli, Edward Benzel, and Said Naderi. It's spinal cord damage, cervical nerve root injury, C5 radiculopathy, dural tears, brachiocephalic vein injury, and vertebral artery injury that we will discuss about it. And then carotid artery injury, graft complication, vertebral avascular necrosis, ventral plating complication, dysphagia, esophageal injury, tracheal injury, recurrent laryngeal nerve injury, hypoglossal injury, thoracic duct, sympathetic cane, excessive bleeding, and post-operative hematome. This is all complications that might be happen in ventral approach. And vertebral injury itself is occur in approximately 1% of case, it's usually caused by lateral use of the cutting burr. So we are working too laterally of the midline. And one note is we didn't respect the midline. It's very important to respect the midline. As a spine surgeon, midline is the safest area. It's on the contrary, in brain, midline is the dangerous area. So in spine surgery, we have to respect the midline and stay in the midline, avoid lateral part. Longus colli muscle and the ancovertebral joints is the key structure to identify the midline. And the other thing is the ventral cervical bone resection should not be carried out of wider than 2 centimeters. And it's maximum. And the medial border of the foramen transversarium from one side to the opposite side is only 3 centimeters. Then we have to think also for the abnormally position of the vertebral artery itself, because sometimes the vertebral artery is shift to the midline, and we have to very careful about it. It sometimes happen. And this is the journal from World Neurosurgery about the incident of vertebral injury in cervical spine surgery. You can see this is another journal about vertebral artery injury in cervical spine surgery, also from yeah, this is from SNI. It's about the vertebral injury in cervical spine surgery. So many researchers already write about this, and this is the vascular relationship that we have to remember, that the vertebral artery is located. Sorry, I will try the pointer. Yeah, that is the vertebral artery, and this is the internal carotid artery. Internal carotid artery and the inner jugular vein is located in the same position, and this is the outer jugular vein. And this is just lies left and right side beneath of the spine itself, so it's very close, the running track of the vertebral artery, I'm sorry. And we can see that vertebral artery is around go along the foramen of intervertebralis, and it's long, and after C2 it will go into the lateral and lies on the bone of the C1 and then enter the dura to the brain. So this is the part area when sometimes when we drill C1, and it will injure the vertebral artery itself. And this is the relationship with circulus of Willis. You can see that this is the vertebral artery. If we talk about complication, we have to talk about the anatomy. And this is the circle of Willis. We can see this is the basilar is part of the two vertebral artery, left and right side. And this is the relationship to the brainstem. We can see in schematic this that the vertebral artery become basilar, and it's going to the anterior from posterior meningeal branch, from posterior part, sorry, and it lies on the anterior of the brainstem. And now this is what we need to understand together, that we have to remember that this is the this and the body of the vertebra. And when we do drill, actually this is the only safe zone that we not injured vertebral artery. Then when we going to the lateral side like this is the longus colli, and it will we can go lateral than longus colli, but we cannot go lateral than uncinate process, because it's the vertebral artery. So in my personal recommendation to us that it's better we not more than longus colli, left and right side. This side, we don't have to expose this when we drill and it's become going down the bone. We have to stop, and we can start from here, and we can drill 30 degree to this side, but not to more than this side. And this is when, if you see from the anterior, this anatomical part, that we can drill only till this side. So when this part going to lateral and the bones start to going down, I mean, it will close to the Unkinet process, and we have to stop. Now this is the relationship of vertebral artery, that is for segmentation. This is the paraforaminal, this is intraforaminal, this is C1, C2 part, and this is intradural part. We can see that when they reach the C1, it will cross it. Sorry, it will going to that lateral and touch the superior part of the C1 bone, and it will curve into the intradural part and intracranial side. This is the bone of C1 and C2. We can skip this. We can see mostly happen the vertebral artery injury is when we do the from the anterior. I mean. Now, if we do anterior approach, is when we try to drill the C1, C2, C3, and we going too laterally, and it's we go more lateral than the colmus coli itself, and it will injure. This is the posterior aspect of when we work from posterior, and this is the relationship with the artery itself. We can see. And this is the anterior aspect. And this is the segmentation that already talked. Now, this is the case that in my whole life, I never forget. This is happened in 2008. The patient came after gunshot wound in the discotheque. The patient got shot. It's a fight between police and the military, and one got shot. And what happened is like this, the bullet is through the bone and got the vertebral artery. The patient came to emergency room, is not in shock condition, so it's stable. But when we do surgery, we open, and then all of a sudden when we take some hematome here, and then it's very, very, it's 2008. At that time, I never forget about that, and it's very, very, the blood is so fast, and we use two suction, and it cannot catch the blood. And lucky that at that time I was doing also brain surgery, and I'm doing clipping. So I have my own clip set, and we clip this part. And then we cannot do reanastomosis because it's the vascular is already unidentified. So we just clip at the two sides, and then do the debridement, find the bullet, and then close it. So I didn't try to direct anastomosis this part. And this is only one time in my whole life, and I hope it's never happen again. And this is the other thing that it can injure vertebral artery when we do drill, like I said before, and we do we already do the drill from this side, medial to longus coli, but the angle is more than 30 degrees. So it will injure also the vertebral artery. So this is also the other what's happened in vertebral injury when we try to do a C1 laminectomy, and in a case like syringomyelin and another thing, and we do more than 7 millimeter to the left and right side, and we use the surgeon use monopolar. Sometimes this is a venous plexus here that will bleed before we reach the vertebral artery curve here. And the vein plexus bleeding is a warning for us to stop, because after this venous plexus, it will be directly face to face to the medial border of the vertebral artery in this curve of superior C1 part. And what should we do? I personally have only one experience in my whole life. So what we do is doing emergency clip But lucky at that time, the patient is not die. And we try to find the reason why. I will tell you the reason after this. Then this is the emergency clip that we use, but sometimes the injury is will not make the dissecting of the artery, so we can have a time for angiography and find where is the rupture, if it's very, very small rupture. And some in the textbook say that we can do embolization. I don't know. I'm not a vascular neurosurgeon, but it's written on the book. And the other is trying to do reanastomosis. This is the reason why if we seal the other vertebral artery, there's a theory that sometimes people have hypoplasia vertebral artery. Then that's the reason why when we do double clip here in this side, but this side can compensate to basilar artery, so the brainstem still got the supply, a good supply. And this is another grading of the vertebral artery anomaly. And actually, when we do the dissecting to avoid injury of vertebra, we have to remember there's 3 danger area when we do approach in anterior approaches. That the first area was the carotid sheath and the friends here, and this all should be taken and pulled to the lateral side of ipsilateral to the surgeon side. It's very important. And the second, this is should push to the contralateral of the surgeon side, and we can if we are working in C5, we can feel the thyroid gland. But if we working under the C5, maybe we cannot feel the thyroid gland, but we can find this space. And the third danger area is if we do a straight line like this, we will directly reach the vertebral artery. So all we need to do is find this space and then find the longus coli here. This is a very direct, safe approach. When we find this, all this structure, we can pull it and we reach the longus coli here. And then we all the things that we have to do is find the other longus coli here, and it's a safe, very safe surgery. And the second is esophageal injury. It's also happened to me in 2012 and 1 times in whole life. This is a woman. I'm forgot about 42 years old. She came with to us with cervical myelopathy of C4, C5, if I'm not wrong. It's happened in 2012, and the patient we do surgery at that time, and the esophagus is very thin. It looks like longus coli, so it's happened. I burned the esophagus with monopolar, and it's tear apart. Now this is, and I didn't realize it until what happened next. It's a rare complication, and it's following ICDF surgery, and no standard diagnostic extrahepatic strategies have been established for this disease entirety. And indisputable early detection is very crucial. We detect at that time at the 3rd day, and then it can give serious complication. Intubation sometimes needed, and we need absolutely exploration. This is the journal that describe about the esophageal perforation associated with ACDF. This is another journal we can see, and this is the other journal also from Jae Sung Park and friends, and it's about esophageal injury after anterior plate fixation. This is another journal about delayed esophagus perforation. This is what happened actually in my case. Now, at that time, when we try to do this, sometimes we are miss that this, if the esophageal part here is very thin, it will lay here. So at the time when I see this side, I thought it was the longus coli, but in fact it's the esophageal that's very thin lay here. And then I tried to put some monopolar here, and then open it, and then I can see the muscle here. That's the time that I start to realize maybe this is esophagus. And then I try to do the suture in this part because it's only 2 millimeters only. Yeah, and then I do the suture, and then we go to the bottom of that part, and we can find the long musculi in the end. And then we do surgery. We do the ACDF, the dissectomy, and this is how it looks like before the injury. But it's not clear like this. It's very difficult to find this perforating like this. And at that time, the patient come to me in the third day with a very hot feeling in the neck, and she feels that she cannot eat well, and the upper chest is very heavy, she said. And then we consult to the ENT surgeon, and they do the barium study, and we can see the feeling of the barium. But this is not the patient, but I put it as an example. And what we do is barium study, and then the patient actually every time they eat, it will collect here. The fluid will collect here. It's only 2 millimeters before, but it will collect here, and it's become an infection. And then if we suspect esophageal perforation, we have a content leak in the chest, and we have to do this chest drainage as needed. But fortunate, very lucky that it's not happened to my patient. And in uncontained leak in the chest, and esophageal stent and laparoscopic, and uncontained leak in the mind. This is the algorithm. And this is the Zargar classification about corrosive injury itself, and it's about esophageal injury, but this is mostly known after longer time. And what happened is the timing is corrosive ingation, and the phase 1, phase 2, and phase 3, and we have to do follow-up. At that time, when we see the feeling of the barium study, we put oral gastric tube and ask the anesthesian to do reintubation and exploration again. So I did the informed consent to the patient, explain everything what happened, and I said that maybe it's something leak from the esophagus, and the patient agreed to do exploration, and then we find the perforation like this, and it's become wider actually. Then I can find the suture that I put before, but it's lost. So it's not that simple, and then we do the suturing again, and the patient got better, and we do follow up until the next 3 months. And then also we have to be very careful for the stricture happen in the esophageal after we are resuturing. This is the classification of esophageal injury. Yeah. Maybe I would like to invite all of you to come to Bandung in 5th spine masterclass. It's Destando Technique Surgery in June 21, 22. We can do a faculty meeting and friendship. And another is next year is WestCon, 13th annual conference in World Endoscopy Spine Society, also in Bandung City, Indonesia. We can see this white crater and white volcano and some temples. Okay, this is, I'm sorry if I'm taking too much time, Dr. Oscar. This is my only presentation. Thank you. All the best.
Wonderful, wonderful.